Hello, I'm Dr. Pravish, an oral and maxillofacial surgeon, and today we will be discussing on COVID-associated mucormycosis. What is mucormycosis? Mucormycosis is a fungal infection caused by fungi in the order Mucorales. The fungal spores are present in the environment. It is present in the bread mold, it is present in mud, it is present in cow dung or any other unhygienic surroundings. These spores can be breathed in to be deposited in the nose, sinuses, and lungs. Once deposited, the fungus grows branch-like filaments which invade our blood vessels, causing a clot to form and the surrounding tissues to die. Association of COVID-19 with mucormycosis. The CAM or COVID-associated mucormycosis can be concomitant, which comes along with the COVID-19, or it may be sequential, which follows weeks or months after COVID recovery. There are certain predisposing factors for mucormycosis. Uncontrolled diabetes mellitus, immunosuppression by steroids, prolonged ICU stay, comorbidities like post-transplant and malignancy, voriconazole therapy. Outbreaks have also been linked to the adhesive bandages being contaminated, the hospital bed sheets, negative pressure rooms, water leaks, poor ventilation, contaminated medical equipments being used. So, what is the pathogenesis of COVID-associated mucormycosis? Hyperglycemia may lead to increased expression of endothelial receptor GRP78, which will cause polymorph neutrophil dysfunction, impaired chemotaxis, defective intracellular killing, which leads to an impaired immunity. Along with this, if there is corticosteroids or immunosuppressants given, they also will cause impaired neutrophil migration, ingestion, and phagolysosome fusion, which is also going to cause the immunity to decrease. The virulence of mucorales. Iron is essential for growth. The virulence is enhanced when it acquires iron from the host. In conditions of ketoacidosis, the free iron becomes readily available in the serum. Mucorales utilize this excess iron through siderophores or iron permeases. The clinical presentation. Mucormycosis is classified into 5 types: rhino-orbitocerebral, pulmonary, gastrointestinal, cutaneous, and disseminated type. Rhino-orbitocerebral mucormycosis. There may be pain, dental or facioocular pain, numbness or swelling in the affected region, skin or mucosal discoloration or ulcerations, nasal discharge which is bloody or blackish in color, double vision with pain, fever, skin lesions, thrombosis and necrosis. There may be palatal ulcerations which can be seen like this. There may be facial swelling. There can be oroantral fistula which is formed, and there may be draining sinuses. So how do you establish a diagnosis? So it is considered to be a medical emergency, and empirical therapy may be started even prior to diagnostic confirmation. So for radio imaging, the recommended radio image is MRI PNS with brain contrast study. The diagnosis can be done through fungal staining or culture of an appropriate specimen, which will demonstrate the fungal hyphae growth. The Indian Council of Medical Research has given certain guidelines in which they have said what are things to do and things not to do. Let us see what are the things to do. They have said to control hyperglycemia, monitor blood glucose level post COVID-19 discharge, use steroids judiciously, use clean, sterile water for humidifiers during oxygen therapy, use antibiotics and antifungal judiciously. What are the ICMR's things not to do? Do not miss warning signs and symptoms. Do not consider all cases with blocked nose to be bacterial sinusitis, especially in the context of immunosuppressors or COVID-19 patients on immunomodulators. Do not hesitate to seek aggressive intervention. And mainly, don't lose crucial time by hesitating to initiate treatment. So treatment for mucormycosis, primarily we have to control diabetes and diabetic ketoacidosis. Reduce steroids if patient is still on steroids. Discontinue any immunomodulating drugs. No antifungal prophylaxis is required. In medical line of treatment, it is very important to establish an peripherally inserted central line and maintain adequate systemic hydration and start with liposomal amphotericin B. The amphotericin B is going to interact with the fungal cell wall and it is going to kill the organism. Surgery. The surgical part of treatment is basically to debride or remove the necrotic material. So extensive surgical debridement is recommended. So it may be the removing of the dentoalveolar segment, or it can be a partial maxillectomy, it can be orbital excineration, or it can be an extensive surgery to remove the entire necrotic mass. So to conclude, we have to be aware of the disease and its progress. Prompt attention to warning signs and symptoms should be given. A high index of clinical suspicion should be maintained. We need to establish an early diagnosis and initiation of a full dose liposomal amphotericin B while awaiting the results of culture and histopathology. A protocol-based strategy by a multidisciplinary team and a prioritized approach may be the key to success. Thank you.